everyone, and welcome back to OE Headlines, Ortho Evidence's new podcast show where we discuss trending topics in the orthopedic community. My name's Abby Payne, and joining me in studio today is Dr. Mohit Bandari and Dr. Brad Petrazor. Brad, welcome.
Hello, hello.
Good to see you both again.
And you.
We're going to jump right into the show today. We've got lots to discuss. So joining us remotely today is Dr. Steve Papp, who's a co-author of a recent study published in the New England Journal of Medicine called Spinal Anesthesia or General Anesthesia for Hip Surgery in Older Adults. Dr. Papp is an associate professor in the Division of Orthopedic Surgery at the University of Ottawa and specializes in orthopedic trauma and upper extremity. So our first OE headliner story today, Spinal versus General Anesthesia in Hip Fracture Surgeries. It's a draw. So this new study discovered that rates of survival, functional recovery, and postoperative delirium are similar for patients whether they underwent general anesthesia or spinal anesthesia for hip fracture surgery. This work from the largest randomized study ever conducted to compare the two anesthesia techniques. It challenges the common thinking that patients who get spinal anesthesia fare better. In this study, Newman and his co-authors enrolled 1,600 patients from 46 hospitals across the United States and Canada. The patients were all at least 50 years old, had broken a hip, and had previously been able to walk. This study was split pretty much equally, almost 800 within each group. So the findings, 60 days post-op, 18.5% of patients assigned to spinal anesthesia had either died or become newly unable to walk, versus 18% of patients who received general anesthesia. When looking at mortality at 60 days alone, 3.9% of patients who received spinal anesthesia died versus 4.1% who got general anesthesia. And finally, the researchers also examined post-op delirium. Roughly 21% of patients assigned to spinal anesthesia experienced delirium versus 20% of those assigned to general anesthesia.
Well, Steve, thanks so much for joining us. It's great to have you here. And we're just going to talk about this New England paper, and that's amazing. Can you give us just a little bit of a brief background to this paper, and then tell us how it's affected your practice and what the response to the paper has been?
Sure. Well, first, thanks for having me, and congrats. I want to say to you guys on this podcast you've had going. It's been really interesting, and I got to say, during COVID, it was like the only normal thing I had going for me was watching you guys. So congrats on that. But to answer your question, Brad, I have to say, obviously, the first author, Mark Newman, is an American anesthetist, and he's a brilliant researcher. And really, they just asked us to jump on the study, so I can't say that I was involved from the beginning. But the impetus was like a lot of studies that obviously your group has driven. Is there was a lot of push that spinal anesthesia was the better way to deliver care for hip fracture patients, but not a lot of sound evidence. Example, level 1 evidence randomized trial. And I think this one is a perfect one that you can do. I mean, this is a fairly straightforward one. Look for some of the easy answers you can give, spinal versus general. And so I think the question was, does this make a difference in outcome like people maybe think it does? And so that's what was the impetus for the study. And we were recruited as one of the studies to enter, so I can't say I was involved from the beginning. Again, Mark is an unbelievable researcher, and I can tell you, if we ever deviated from study protocol, he was honest like you wouldn't believe. So I knew we were involved with a winner, and got this great project done. As far as answering your question about does it change our practice, I think it has. In our, I would say, especially more and more our physicians, surgeons, and anesthetists are trying to practice evidence-based medicine. I think this gives them some feedback that they can individualize to the patient, that both of these practices are safe, and so there's less impetus or I guess the word would be guilt that we have to use the spinal because it's mandatory. And I think that we've already noticed that. Does it change my practice? And the other answer is, of course, it's always hard. I don't want an anesthetist to tell me whether I should use a nail or whether I should use a DHS. So I think there's also a certain political correctness because they're delivering the anesthesia. So it might be a better question for anesthesia, but certainly I think it's already changed our practice here in Ottawa.
first of all, thanks so much for joining us. Can you speak a little bit to what the reception of this paper has been in the community? I'm curious what others who have approached you about this paper have said about it. I mean, are they generally saying, yes, I always knew this, or wow, this is a surprise to me?
So this paper is recently published, so I wouldn't say that it's well known across community centers yet, and hopefully we can get that message out. But I would say that the most common feedback has been from orthopedic surgeons or anesthetists within the academic centers, in particular within Ottawa. And I think the reaction has been positive. Congratulations on the study. And this is great evidence to add to my practice. And yes, I'm surprised a little bit with the results. I certainly thought that the teaching or the dogma was always that spinal was going to be proven to be the better way to go. And the study is fairly convincing with a large amount of patients that they're both pretty safe practices. The lines are pretty parallel as they follow each other out. They seem to be both reasonable choices for anesthesia.
As someone who is enrolling for the trial, did you find it surprising, or were you we always try and guess sometimes, even though you're not supposed to, but did you find it as a surprising thing, or did you say, yeah, no, that's...
I would say that I did find it a little surprising. I thought spinal might turn out to be better. I guess when you look back at it, you say, there are so many factors in the patient's outcome, the patient's frailty score, the patient's medical problems, how well other factors were given, like, for example, close monitoring, blood transfusions at the right time. So there's a lot of other factors that go into a patient's care. But in such a large study, this might tease out that spinal is better. So I'd say probably, if I thought back, I'd say like teaching goes, I'd say I was a little surprised. But there's so many factors that go into a patient's care when they suffer hip fracture, and this is just one of them. And so at the end, as the paper alludes to, with a lot of times when we're looking at things, we may be looking at old techniques that are done, and I think that in particular both spinal and general have in themselves improved. So delivering those have improved to the point where they've become both safe and reasonable ways to deliver anesthesia.
Well, Steve, thanks so much for highlighting this really important paper, and sincere congratulations really on all of the success and being involved with this study, and looking forward to seeing the message get spread a little bit and really helping us individualize our patient care in good conscience and in keeping with best evidence. So thanks so much again for being here to talk about it.
Yeah, thanks so much, Steve.
Thanks, guys, for all the work you do. It's really, really great to watch you, and I'll keep watching.
All right.
Okay, so now on to our Fast 5 stories. Is 2 years too much? PROMs for total knee arthroplasty. Results presented at AUKUS annual meeting last week suggested that patient-reported outcomes for total knee arthroplasty beyond 1 year may be unnecessary. The authors conducted a retrospective review of prospectively collected patient-reported outcome measures, or PROMs, for 1,093 primary total knee arthroplasty procedures to determine the value of long-term PROMs in primary total knee arthroplasty. Researchers concluded that 1-year PROMs were as clinically reliable and meaningful as 2-year PROMs. While long-term follow-up after total knee arthroplasty remains important for implant survivorship and function, these findings question the necessity of in-person visits to collect PROMs beyond 1 year and suggest that 1-year outcomes are reliably predictive of longer-term outcomes for peer-reviewed publications. So, Mo, Brad, what are your thoughts on this?
Yeah, I mean, I think this is, first of all, I congratulate the authors for doing this, because it's been by convention that 2 years is the standard. In fact, if you're looking to submit to most journals, when they're looking at functional outcomes or quality of life, it's always been 2 years. I can't remember ever having a real defense for a 1-year functional outcome. You have to make a strong argument. But I actually think this is really important for a couple of reasons. One is, for those who are looking to do research in this area, 1-year outcomes that can be used specifically for patient important outcomes in this particular case are hugely valuable for one reason: it's cost. Like running a large multinational study where you're collecting this data, first of all, it's very hard to collect at multiple years. But secondly, if you can find a surrogate, which is 1 year is the same as future years, it provides a huge amount of efficiency in conducting this data. So I think you'll see lots and lots of of studies coming out now, potentially, if this is a warranted finding, which I think it's pretty important for us to be thinking that way, it's going to help us. It's going to help us actually move research forward a lot faster than the past. Now, does it mean that 1 year outcomes should be sufficient in doing research? Probably not, obviously not. But the question is, we still need to have that early indicator for the midterm, which might be 5 to 10 years, and then later than 5 to 10 years, especially in joint arthroplasty.
Yeah. Well, that's the important bit. And they mentioned that too, that you need long-term outcome period for survivorship and what's lasting and what isn't. But we're also forgetting the early onset effect of the treatment itself. Like the treatment itself is a pain reliever. You've got arthritis one day and the next day you don't. And so by that aspect of the procedure, you're going to feel better within a year. Now, arguably, if you were looking at little nuances of function between two prostheses, you may want to take that out to the 2-year mark. But by and large, the treatment effect of a total knee is going to be within the first year. But the long-term outcome is very important to make sure that nothing's failing early, and the implants that are on the market now are lasting with their peers, so to speak.
Right. The argument, this is basically almost a natural, in a sense, a natural history experiment, in which you're looking at data. Now, was it conducted that way? No, it's a retrospective data set. But if you're prospectively collecting data, you're looking for the point at which it plateaus. So the suggestion here is that for the most part, you're not seeing incremental or big enough improvements from 1 to 2 years that it makes sense not to consider it almost a plateau for a period of time. Right. Now, there may be additional plateaus that come up further, but it's a very reasonable assertion.
Yeah.
Okay, fantastic. So on to our second story. Is there trouble in PRP Paradise? In the past few months, there seems to be a lot of negative findings regarding effectiveness of platelet-rich plasma. 2 studies recently published in JAMA had similar conclusions. The findings were not in support of PRP over placebo. So let's dive into these 2 JAMA studies. The first, by Kearney et al., was published in July 2021 and was an RCT of 240 patients measuring the effects of 1 PRP versus sham injection on tendon dysfunction in patients with chronic mid-portion Achilles tendinopathy. The primary outcome used a VISA A score, which was measured at 6 months after treatment allocation. The mean VISA A score values in the PRP group versus the sham injection group were 54.4 versus 53.4. So the adjusted mean difference was negative 2.7. Therefore, these findings did not support the use of treatment for chronic mid-portion Achilles tendinopathy. The second study by Paget et al. Came out at the end of October 2021, so a little more recent, and it was also an RCT which included 100 patients measuring the effect of 2 PRP versus placebo injections on ankle symptoms and functions in patients with ankle osteoarthritis. They used the American Orthopedic Foot and Ankle Society score to measure the outcomes over 26 weeks. So this is a range 0 to 100. The higher scores indicate less pain and better function. The minimal clinically important difference needs to be 12 points, just to note. So compared to baseline values, the mean score improved by 10 points in the PRP group, went from 63 to 73 with a p-value of 0.001, and 11 points in the placebo group from 64 to 75. So it's a p-value of 0.001 as well. The adjusted between group difference for 26 weeks was -1. So it's p-value of 0.56. The results of this study as well do not support the use of PRP injections for knee OA, or for ankle OA rather. So interestingly, a comment and response was published in JAMA last week in response to that first study that was published by Kearney et al., suggesting that there were numerous methodological issues in the article. So Mo, what are your thoughts on this?
Yeah, I mean, this is the ongoing debate. I mean, PRP for many, many years, I'd say well over a decade, has been looking for indications, right? So it's almost like you've got this potential wonder product or tool that we're looking for an indication. And it's been, I mean, multiple double-digit indications have been tried, and it's not working in a ton of areas. If you look at the American Academy, their guideline that came out on non-operative approaches or minimally invasive approaches for knee osteoarthritis, and we've talked about this already, in the summer of this year. Same thing, right? PRP gets sort of a limited evidence statement, largely because there's huge amount of variability in that data set, and I think that's the challenge. But I'll also put a plug in for our own OE original. In this case, it was an insight that was published. It was August 21st, 2021. We'll make sure we put that out. But in that, we quote, and I'll get your take on this one, Brad. They quote the following. There are now 400 complete or ongoing clinical trials evaluating the use of PRP and over 800 evaluating the use of mesenchymal stem cells in the range of clinical applications, a ton of them. Many of these trials have been designed and started with little knowledge of what preparations contain and without comprehensive scientific understanding of the mechanisms by which they may produce their benefit. They go on to say, and this is a paper by Murray et al. In 2018, writes, we'll only truly know if biological therapies can be of therapeutic benefit if our community, our scientific and our clinical community, accepts that shortcuts cannot be taken and adopts a responsible approach to the use of biological therapies, including the generation of both an evidence base to support them and an understanding of the principles they use.
Mm-hmm. Yeah, that's a good point. So there's a couple of comments to make on that in my mind. One is the PRP itself, and you mentioned the biologics. There are so many different types. There's so much noise in the system in terms of, as you said, is it mesenchymal stem cell from fat, from bone? Do you have embryonic stem cell? Do you have stem cells that have been tissue expanded or minimally manipulated? Because there's all these different sort of things. So when you look at the trials, stem cells is a group, but there's 10, 11, 12 different subtypes. So there's lots of noise in that. And it's the same with PRP. You can spin it down and one system will remove the blood product and save the biggest platelet layer. Others just there's no wax plug and it's all there and you kind of have to carefully pipette it out. So there's definitely a little bit of noise in the system. That's true, and that speaks to all of the different trials and not seeing something. Is there a signal? Not sure yet. And we're seeing more and more that maybe there isn't. With this particular trial, I would be wanting to know, did both groups achieve a benefit? Does just needling the Achilles achieve a benefit? And the answer is not really, actually. It doesn't look like the time points are all fairly similar between the two. Bit of background with the Achilles, though. Insertional Achilles tendinopathy or Achilles tendinopathy chronic is a very recalcitrant and difficult thing to treat, period. And, physio, extracorporeal shockwave therapy, does that have a role? Yes or no? Big things going on there. But the problem is, the ultimate thing is sometimes surgery. And again, it speaks to what we've spoken to before. Do you want someone to open you up, cut your Achilles out, advance your Achilles, shave off your heel, and all that sort of stuff? Or do you want to drop a couple $100 and try this? Now, that's one way to think about it. And I'm not advising that way, but I'm suggesting that that's why it's still, people are studying it and trying to find that treatment because actually patients are like, what else can we do? You're telling me I can't do anything? So that's the conundrum. It's a clinical conundrum, but it's also a methods conundrum because there's so many variables in the variation in how the thing is injected.
Yeah, and the truth is, when you talk with clinicians who really get benefit, and they believe wholeheartedly that the way I do it is the way to do it, we encourage that group of individuals to publish their results and actually publish them with the context of a proper experiment rather than in my experience or in my hands. Now, there's a lot to be said about in my experience and in my hands, but from the point of view, if you want to get others to adopt your view and what's happening, you've got to be able to collect that data and move it forward. So I say to those who, I say to this group who's actually published the data, they've put out a narrative. If you don't agree with it, yes, you can go and say, well, I don't believe there's all kinds of flaws there. But the truth of the matter is they went out and did to their best a trial that they set out to hopefully try to solve the answer. If you believe that the answer is an incorrect one based on some of the formulations, well, then it behooves you to get out there and evaluate and test it. There's no value in just attacking someone else down rather than trying to build yourself up by building your own evidence base. So I would encourage all of those who believe strongly that PRP has a role to get out there, collect their data, and present it. And I think we'd love to be able to present data that's positive. It just happens to be that these two studies recently come out are negative for a host of reasons. But it gets back to originally that whole issue, right? And I'll just leave with this one, Abby. This one I think is pretty important. This goes back to our insight that was published. But they write there again that currently there is a lack of consensus on the optimal preparation, the source, the method of delivery, the dosing of biologic therapies. And this goes across most areas, but particularly in sports medicine. And it's exacerbated by a lack of sufficient experimental detail that's not available in most published studies. So ultimately, what is the call? The call is we need to identify the biological target for different tissues and diverse pathologies. And ultimately, the ideal therapy should depend on the goal of treatment. And I think we've got to get away from, we have a product, we got to apply it everywhere and just start using it everywhere, and a bit more systematic approach.
Okay, great. On to our third story. Hardware removal may be more complicated than you think. Hardware removal is one of the 10 most commonly performed orthopedic procedures. In a recent study in JBJS by Calamayal, complications of hardware removal results outlined an overall complication rate of 9.6% in a cohort of recently trained orthopedic surgeons in the United States. Specific complications include wound healing delay and failure at 2.7%, infection at 1.6%, unexpected reoperation at 2.5%, readmission at 1.6%, continuing pain at 1.2%, and life-threatening complications at 0.4%. So although some of these complications do have low rates of occurrence, it still seems that there's a definite risk here. Mo and Brad, what are your thoughts?
My thoughts are that there is a definite risk. I completely agree. And so for the vast majority of patients, for me and for probably a lot of people, hardware stays in unless it bugs people. And then the question is, if it bugs people, how certain are you that it bugs people? And sometimes hardware, especially in ankles or prominent pieces, clavicles for that matter, you can just feel it and it just rubs and it bothers people. And people don't like it and they want to have it out. But I go through this kind of list of things because you're going through previous scars. You're sometimes had multiple operations. Dealing with fractures is different than pure elective surgeries. General complications are higher. So it's a long discussion about the risks and benefits of hardware removal. But there's a lot of people who still want it out because it bugs them. And then there's also a bit of a psychological component. Some people just don't like metal. Right. So.
Yeah, and then the argument also is that when they have it in, they have this perception that certain weather, certain times, their ankle aches because they have it in there. Yet you can tell them, well, if you take it out, there's a 50% chance the pain won't go away. But the truth is, there is a sense of calmness that it's out. So therefore now I can heal, or I can finally heal without having this foreign body in me. The downside, I think, which is an important message from this Kellum paper, which is nothing we do is truly benign. And ultimately, I think we have to be very, very careful to say, well, it's just a quick, removal. It's a quick, percutaneous, screw removal. Yeah, great. 99 times out of 100 it is. But in the event that there's a complications for something that the expectation is going to go very well can be very, very, further traumatic for patients. So I do think, getting as much light on this issue is an important one. Are there things, Brad, though, that you would almost uniformly say it's best to probably leave it in? Are there specific types of implant removals that you think it's not worth, even if the patient specifically wants, you give them additional counseling on the risks?
Yeah, so intramedullary nails are one of them for sure. I will have a discussion about cross screw removal because that's the most bothersome. Yep. But if the nail inside, I strongly advise that it stays unless it's either infected or something different. So that's one of them. And in fact, I had a patient about 3 months ago who was absolutely wanted her tibial nail out. It was the hardest thing to take out I have ever had to take out. So that's one thing. Anything that's really buried that I just know is not bugging the skin, the soft tissues, I strongly advise to just leave it in, unless it's infected or some other mitigating circumstance.
Yeah, taking the screws out is one thing, but taking the nail out itself, right? I mean,
it's often harder to get it out than it is to put it in.
Yeah, totally get it. Okay. So good paper overall.
Yeah.
It's good to get that information out.
Excellent. So on to the fourth story. Could AI predict sports injuries in athletes? Sports are gradually entering a new era in which artificial intelligence might act as an assistant coach. Algorithms could enable athletes to train smarter and avoid a career-ending injury, allowing them to compete for a few years longer. But the technology's success depends in part on the ability of data scientists to prove to the world that there is some means to this process. In a recent article, data scientists used a sensor package inserted into the clothing of 26 elite football players, recording 931 individual training sessions over the course of 23 weeks. From this, the researchers extracted 12 variables, including total distance run faster than 5.5 meters per second, and the number of high-intensity accelerations and decelerations, which put extra stress on the body. The variables in Rossi's model included an athlete's previous health issues, the total distance that they have covered in a training session, and the distance covered at high speed. By asking a series of questions of the data so far, the system is able to predict 80% of injuries, although for some recurrent health issues, such as specific sprains and strains, the system can spot the warning signs almost every time. So, Brad, do you want to start on this one?
Well, yeah, I can start on this one because it's essentially a big data thing, and using AI, of which this platform is a big proponent of. So I would first start by saying, what do you think about the big data and the AI concept of this? And then I'm gonna say,
did you see the bait and switch? I literally thought, I don't have a comment. I'm just going to dump it.
I do have a comment.
At this point,
it's a reactive
At this point, I'm
comment.
going back. Like, okay, good. I can actually think of something to say. You know, we got it. All right, fair enough. So, Brad, I think, as much as I'd like your opinion on this, I'll go ahead and.
I know you want to speak to it, but I also want to speak to it.
Well, I think the thing that I really like about what I like about this movement and this area of work is really trying to sort out ways in which we can get information through wearable sensors. If you're looking at now the information that's coming in, I think from that particular study, they talked about, bodysuits, they talked about vests, bands, all kinds of things that can measure heart rate, oxygenation, they can measure kinematics. That kind of information is powerful. The problem is it becomes like, well, what do you do with every little perturbation of information? If you get an MRI in most healthy adults, you're going to find something. And then the question is, now, is that sort of the false narrative that we're going to create? The problem with big data is it's not usable data, and there's so much of it that you need to have appropriate algorithms. So I get the idea in this work and saying that we can create algorithms, which we've talked about this time and time again, are just good old-fashioned regression analysis. Predictive analytics is basically what features of that individual can we glean, and then can we identify that person at risk. I'll be shocked though, Brad, if you couldn't already, for the most part, for the most things, make very reasonable guesses, sort of the standard statements around, well, if that person, has had a prior injury, lo and behold, they're probably more likely to have a future injury. And the question is, how do you actually train them? How do you manage them? Yeah. Different in sort of, in among high performance athletes and sort of your regular sort of, local sports teams. But I think the principles are the same.
But you mentioned the word principles, and I just want to bring up this statistician from Germany. He works at the Max Planck Institute, and his name is Gerd Gigerenzer. And I think he's brilliant because he talks about when you have risks, when you have all of the data, you can put it into a good machine learning algorithm and pick out what you think the probabilities of the risk are going to be. But he says when you're dealing with uncertainty, and life is uncertainty, perhaps standard things, as you said, principles, or what he calls and everybody calls heuristics or rules of thumb, are actually just as valuable. So don't overtrain your players. Listen to your players. Wear a brace if your ankle feels stuff like that. And you equate that to surgery all the time. You can go through think about open fractures even. You can go through all the algorithms that you want, but if you say, you know what, the dirtier it is, get to it quicker. Heuristics can also predict, just as you said, principles. And I think that we forget the use of that common sense and principles.
Understood. Yeah, that makes a lot of sense. Yeah.
On to our fifth and final story. UFC fighter returns to the ring after hip replacement. Frankie Edgar, 40, returned to the ring on November 6, 2021 in UFC 268 versus Marlon Vera. In the third round, Vera landed a powerful kick on Edgar's chin, ending the fight by TKO. After the fight, Edgar sat down with the Champ and the Tramp podcast and revealed that he had undergone hip replacement surgery 7 months before this fight. He reported that his hip felt great following surgery and that his recovery was a huge accomplishment in and of itself. However, a lot of people in the UFC community are wondering if it's time to call it quits. Brad, what are your thoughts?
Actually, can I say something?
Yes.
You know what? I like to hear what Brad has to say. Brad, I have lots to say, but I like to hear what you have to say about this.
Firstly, Frankie Edgar is a stalwart in the MMA community. I mean, the guy is amazing, and he's been wrestling since he was a kid and all that sort of stuff. And he's got the whole game and the whole package. And 7 months after a total hip, I listened to that podcast. He's got a few other health issues that he's getting angry because he clearly doesn't want to retire, but he's also understanding that his body needs to be healthy, and so he's seeking other things, and he openly said it. But the thing is, a total hip after MMA after a total hip. It's a hard one. The shearing forces on the hips are just different than everyday walking. The hips were, originally designed to get people walking, essentially, not to do the heavy duty things. And in fact, Dr. Chris Rayner's got a good video actually on it, so he looks at that. So I draw everybody's attention to that. But it's a tough get over to be in the ring 7 months. That's all.
Yeah, and I think, it's not a lot known, and appropriately so. I don't think his personal life should be, on display for everyone else. But, the questions you immediately think of, what type of hip replacement was done? Yeah. Secondly, was it truly, it could have been oversurfacing? I doubt it, but, I think I'm hearing the word total hip replacement. Also, what was the surgical approach? I mean, there are different approaches, and you can imagine sort of the way your hip, as a non-MMA expert, but is contorted, that there are definitely positions that put your hip more at risk for potential dislocation. So, and there are also newer hip designs and newer approaches that actually limit dislocation to a greater degree. So there's a lot of unknowns there.
What bearing surfaces were
right,
used?
but at the end of the day, the point is there is no blanket statement that therefore because one elite athlete, superbly motivated, probably the top of the game, was able to do it, means that the rest of the group should be able to do that with total hip replacement. I do think we have to be very careful and selective about how we interpret this information.
Yeah, he was prehabbed at a different level than other people.
Okay, fantastic. So we are officially out of time, but we'd like to thank the OE community for tuning in again into the 5th episode of our OE Headlines podcast. We encourage everyone to submit any questions or topics to headlines@myorthoevidence.com. Mo, Brad, thank you again.
Thank you. It was a lot of fun.